Welcome to all our participants. We're very glad that you're here. This is the fourth in a series of webinars that we have titled The Doctors Are In. This medical lockdown really exposes the tensions and flaws that have always existed in the dissemination of scientific information in our country. And at AAPS, we believe that the best way to stay up for us as practicing physicians is to compare notes with our colleagues in clinical practice. So this is a webinar series curated by clinicians for clinicians. We want to get information to you that you can use now in your everyday practice. I want to remind you that we have a series of small discussion groups that we're running in parallel with this webinar series. And if you'd like to join a small discussion group, there's still room, and in the follow-up communications, you can let us know that. Before I introduce Dr. Dobken, I'd like to announce our next speaker for May 28th, 2 weeks from tonight. Our own Michael Robb is a past AAPS president and a current board member, a longtime board member. And in his presentation, he'll use the controversy around hydroxychloroquine as a way to illustrate the general problems of translating science into clinical practice and communicating that knowledge to patients. I'd like to introduce Dr. Dobken now. Dr. Dobken practices as a pediatric immunologist allergist. He is assistant clinical professor at Cornell Weill School of Medicine, and he's also adjunct assistant professor of public health at New York Medical College. He holds a certificate in bioethics from the Center for the Study of Society and Medicine, the College of Physicians and Surgeons, Columbia University. Dr. Dobken's presentation will explore the tensions between quarantine and civil liberty and the role of ethics in clinical practice under public health orders. And we want to link this topic to our other topics that relate to practice in the current pandemic times. Dr. Dobken, I'm pleased to introduce you.
Thank you, Dr. Emmons. And I want to begin this webinar by thanking the AAPS for allowing me the privilege of addressing you about this very complex and difficult subject. I hope to unpack a bit about bioethics and its role in the COVID-19 crisis, along with the tension of quarantine and civil liberties. But before I go there, I would also like to acknowledge and thank Dr. Jane Orient for including me in this webinar, and especially thank Jeremy Snavely for his absolutely instrumental assistance in putting together this project. I am a clinician, I'm a physician. I'm not a lawyer, and I'm not a legal scholar. So this is going to be a discussion on how the law impacts us. But my conflict of interest declaration is that I have no conflicts of interest. As I said before, I'm not a lawyer, but what can I tell you? That just goes along with the territory. I'm going to give a cryptic overview of how the discipline, how the neo-discipline, as it's called, of bioethics came into existence. This is going to be an overview, but it should help place in perspective what bioethics does, how it does it, and what is the contrast between bioethics and ethics. We're going to talk a bit then about what quarantining, bioethics, and COVID-19 imply. And just to review very quickly the principles of the bioethics enterprise standby. Number one, the relevance of informed consent and how that contributes to autonomy. Beneficence, non-maleficence, and justice, which for those of us who are still Hippocratic in our beliefs would translate as first do no harm. Public health law and medical ethics will be the target that we're aiming at, and what the impact of pandemics such as COVID-19 do in the setting of suspending ethics, and why? I'll start with a quote from Gandhi on the American democracy, a kind of gentle critique of what we are and what we've become. Gandhi said about American democracy that I think it a grand idea, and I hope someday Americans might try it. While bioethics as a discipline has more or less the same problem. It's a great idea, but execution is both flawed, and that has become highlighted in the COVID-19 pandemic. We're going to explore why. To define ethics and bioethics is a monumental and hard task. I will try to make this fairly simple and fairly straightforward. What are ethics? Ethics are, in effect, an attempt to formulate principles of conduct in our lives based on ideas and acts of generally accepted goodness or badness. The definition of goodness and badness, of right and wrong, has been argued and discussed since the time of Hippocrates, 2,500 years ago. The Aristotle, Plato, all of our Western culture ancestors that discuss this were never able to come up with one acceptable, concrete definition of good or bad. That changes with the notions that society and culture hold, but functionally, in terms of how goodness and badness may be discussed, really relates back to what are ethics. Ethics are about discussion. They're about concept. It's about study. It's about analysis, which is part of the root of the word ethics. But the important message here is just how different are bioethics from ethics. They are not one and the same. Bioethics and ethics are not synonymous. Bioethics are about people. They're about you, they're about me. It's about the medical care we receive and we evaluate. Bioethics was born in the 1960s as a public service. It was designed to reduce the complexity of issues confronting patient, family, and care team while avoiding medical paternalism and jingoistic explanations that tended to confuse patients, their families, in the fog that surrounds a stressful medical situation and its management. In effect, bioethics came about because the goal to replace Hippocratic ethics became popularized. We're going to go over that a bit, but the 1950s, 1960s, in the period following World War II and the Nuremberg trials, where the Nazi death camps run by physicians were, and we all know this, were accused of atrocious humanitarian crimes. The fact of the matter was, in the 1950s through the 1960s, from the Declaration of Helsinki, which abridged the issue of human rights, and human rights in research especially, but how to protect those human rights, what would happen if those rights were violated, and how to assure them, became a matter of public concern, especially if it was noted that there were several very questionable, very unethical studies that were done in the United States, among other places. But in the United States, and I've only picked two specific studies to cite here. The Willowbrook study was done with children that were multiply impaired but admitted to an institution, and essentially without any kind of consent. the families would leave the children at the Willowbrook School, and it was a state-run school in New York, and the children were intentionally infected with hepatitis virus to find out if a gamma globulin treatment for that hepatitis would effectively address the hepatitis. But it's the Tuskegee study that grabbed news and headlines. The Tuskegee study was done in the South, and it was about the range of syphilis. Let me get this out of the way. The natural history of untreated syphilis. The study was run by USPHS, the United States Public Health Service, from 1932 through 1972. The Tuskegee syphilis study used sharecroppers from Tuskegee that were essentially all African American, very poor, with questionable literacy, and without really being told what the study was about. The study was about the natural history of untreated syphilis. The patients thought they were being treated. Obviously, from the 1930s through the end of World War II, penicillin was simply not an available treatment. But by 1947, penicillin and its ability to treat syphilis was not only well in the marketplace, but also available. Yet the study was not interrupted until 1972. In the mid-1960s, it was pointed out that this was highly unethical. But when it got into the media, it became a reason to attack the physicians who were thought to have no longer an ethic. The Hippocratic ethic was thus in need of, according to the philosophers who took the ethics of this and used it as an example of why medicine could no longer be held to the Hippocratic Oath. We no longer practice the Hippocratic Oath in the eyes of Beecham and Childress, who wound up participating in the Belmont Report, of which I'll talk more in a moment. But the irony of all of this is that it wasn't the Hippocratic Oath that failed. It was the fact that the physicians working for the USPHS were not working for the patients. They were working for the system. They worked for a different employer than the disease of the patient. Okay, that's not working now. The Belmont Report articulated the basic principles of how to protect a person who is in a study. Respect for persons became the major goal of what the Belmont Principles came to mean. The Belmont Principles, and I'll talk about the Belmont Report separately in a second, came up with several different talking points that were the critical aspects of how that discipline would proceed. Respect for persons was considered primary. That meant individual autonomy. You had to be able to say, I don't want to do this, as much as you wanted to participate once you knew what was going on in a study. The protection of individuals with reduced autonomy. In this case, the reduced autonomy was educational, but it could be anything from a patient who has lost capacity after a severe head injury, or any other of a number of causes that left the patient unable to decide for themselves. Beneficence was the translation of doing as much good and minimizing the harms. And justice, which meant effectively equal cases being treated equally, regardless of other conditions such as money or financial support. Bioethics expanded on these principles over the course of years. It has, in the 50, and it probably should be closer now to 60 years, bioethics has attempted to create a framework, a legal framework and a bioethical framework that would underpin the protection of the patient, of the individual who was involved in a study. All of which was to assure autonomy, the ability to make up your mind on how independently you wish to be treated. The instrument to do this was informed consent. My question is, has the bioethics enterprise succeeded? This presentation will ask many more questions than it gives answers, but that's in the nature of an ethics venue. But what about the patient who is elderly or maybe disabled or young? The child has no legal standing. They cannot consent. They can only assent to a dictum or to a treatment. What has happened? What has COVID-19 done to these principles of bioethics? And we're going to look at them in many different ways. The ultimate goal of the bioethical principles, again, came back to respect for autonomy, beneficence and non-maleficence, now separated into two separate categories. Beneficence, doing good, non-maleficence, doing harm, and then the concept of justice, which in our society and culture has come to be very fluid in its definition, as has many of the other so-called value judgments. The common rule was a federal regulation that translated the findings of the Belmont Report into legal obligations. The term common rule refers to 45 CFR 46, the Code of Federal Regulation. It governs research with human subjects. It codifies the ethical principles of the Belmont Report, and it defines what constitutes research, as well as defines what is a human subject. The common rule, again, from the Belmont Report, states certain things, and it's to underpin the creation of the informed consent. The Belmont Report was published in '79, derives its name from the Belmont Conference Center, which is in Maryland, part of what once was the Smithsonian Institute's conference center in Maryland. That's now moved on, but it was published in '79 in response to the unethical studies in psychology and medicine, such as the I'm blanking on that, but such as the Tuskegee study and so on. It articulated the common rule legislation, which we just pointed out, CFR 45. It maintained the principle of respect for persons. Participants have to know about and consent to research. They have to know what's being done and how it's being done. And of course, the notion of beneficence, where no harm is done and maximize benefits and minimize risks. Justice meant fair distribution of costs and benefits, but it meant that everybody derived benefit to the same extent, no matter what their backgrounds might have been. Belmont is a result of the Congress suggesting that we had to have a more comprehensive way of dealing with the subjects of research. And it distinguished between, let me just see, because I can't see this thing. It distinguished between medical practice, which were interventions designed to enhance the well-being of a patient, and medical research, which meant the development of generalizable knowledge. When it became federal law, the common rule, it let me just see this. It assured that the autonomy of the individual was secured through the vehicle of informed consent. Informed consent followed very strict guidelines, and it does to this day. The result, however, of the Belmont Report was the creation of two separate ethical contexts or standards. One was for the private patient, and the other was for the research subject. Well, that's kind of a cheat. The patient, the individual patient was cared for by the medical profession, and those circumstances, the ethics were left to the quote unquote old ethics. That would be Hippocratic ethics. The study subject, on the other hand, was seen as a different, no longer seen as a patient. They became part of this new ethic of protection. But this distinction is quite frankly cheating. Study subjects are patients and vice versa. However, this allowed a bioethical perspective in which the medical needs of the patient or subject became secondary to the needs of the greater good. That view will impact on the ethics of the COVID-19 crisis, as we'll see shortly. Informed consent and autonomy are linked in a number of ways, but the question becomes, how does this principle of respect for autonomy relate back to healthcare? And what does this mean in relationship to patients and their choices? How does informed consent achieve the goals of autonomy? And that's a fundamental question, certainly not one that a waiting room questionnaire, though waiting rooms right now are pretty empty, or an email of a consent document that's sent to a patient and expected to inform the patient what the study or treatment is about, and then what to expect or not expect in that context. For us, for the professionals, we have to ask certain questions. And these are the questions that any professional would want to know, especially when informing the patient about what is going on. Does the public actually understand? We're talking about an infectious event now. Do they understand viral microbiology, infectious disease, immunology, immunohistochemistry, pathophysiology, pharmacokinetics, or the utility of laboratory tests, all from what, a waiting room questionnaire or from an email? The point really is, if you're going to give informed consent, if you're going to look to assure the autonomy of an individual and in a non-coercive way so they can make the right decision for themselves, then those questions about how much actual science the patient understands from the consent needs to be answered. I sit on an IRB, and the average informed consent document mandated by the guidelines that have been provided through the common rule is some 20 to 25 pages long. That's an average. And the language in which it's supposed to be written is to the 5th grade. So patients who don't have even a passing knowledge of English, for example, may be severely handicapped in making decisions for themselves, in assuring autonomy. Has the public health enterprise provided clear concepts and education to the public? And I'm referring specifically to COVID-19. Has any state or federal agency or other government source provided a process of informed consent prior to instituting policies that ultimately control treatment decisions or general social behavior? And I would ask this question: where are the bioethicists? And perhaps better yet, who are the bioethicists? Does the patient really understand what's going on? Do they understand what we're offering and what it means to them and whether it is beneficial or harmful and what are the risks? And how do we assure that that happens? Perhaps taken by extension, even more critically, is what does this mean for the physician? What about the autonomy of the physician who needs to make a decision on a treatment that may be forbidden or prohibited by public health law or by a bureaucracy that determines that a medication hasn't shown enough statistical proof of efficacy? The important part of the patient understanding this is that that is supposed to be the bridge that helps them make the correct autonomous decision about their treatment. So autonomy and self-determination are linked. They're linked in the bioethical paradigm where where we're respecting the individual and their autonomy, their ability to make decisions for themselves, where we're not harming them and we're not withholding information from them that would allow them to make the decision they need for themselves. But the issues that are in the current bioethics literature, especially since COVID-19 was declared, really have more to do with scarcity, a favorite bioethics topic, and its management. Safeguarding communities is number one in the literature. Allocating ventilators, allocating scarce resources, whether it's PPE or ICU beds or prescriptions and so on, are high among the citations that I've read. Ethical end-of-life decisions and triage. I found this to be a particularly troublesome area in the bioethics literature because it is now suggested, and I don't believe it's been effectuated, but it's now suggested that any end-of-life decision-making or triage for the end of life, that those decisions should be passed to a committee that is not in the line of direct care of the patient. Current bioethics are not about the individual. I left off this, I'm sorry. The government public health powers during COVID-19 and pandemic and the management of uncertainty are also hot topics in the bioethics literature. But the current bioethics are clearly not about the individual. The concern and focus are societal, cultural, political, institutional, academic, economic, and only remotely medical. There are no references to be found about specific patient care or physician autonomy or the impact of public health law on the care of the individual patient. Limited or sparse assets, are these to be or statistical prognosis, are these to be the primary or singular basis for ethical or therapeutic decisions? And who makes this judgment? It's amazing, in effect, that children left out of this formula of autonomy, mostly because they're not considered consent partners anyway, are not part of the process of understanding autonomy or understanding consent. The use of strict guidelines to determine what happens to the patient and when it happens has got to be regarded with skepticism. It has to be something that we examine quite closely, because the value of a life, whether it's a child's life or anybody who is not a straightforward consent partner, either by virtue of their disease or by virtue of their capacity to decide, is critical. But who asks us questions as the value of a life? And who has the legitimate moral authority to provide an answer? Going back to this notion that scarcity drives the decision process in an epidemic, we should look at what we did in the 20th century. And the question I have is, would the children of the Iron Lung Age survive to the 21st century? The notion that the epidemic that we're facing is unique and unprecedented is not really quite true. We have faced, as a species, uh, multiple times infectious diseases that did not have a clear-cut answer. Polio is one of them. But in the 1940s, the late 1940s, when a pandemic of polio hit the world, there was more than adequate response in the development of, in this case, the iron lung, a primitive ventilator, granted, but from Norway to Texas, the world found a way to treat the children, to treat the victims of polio effectively. So if we look at what the 21st century uh, defines, decisive and preemptive guidelines that strip the patient or decision maker and physician from the clinical process from the start, deny the patient due process, distorts the meaning and intent of autonomy, even if the bioethics industry continues to label it as ethical. This is a very short list of the recent literature in bioethics, and it does highlight the point about scarcity being more important, the economics of keeping people alive who would probably otherwise die, and the rest of issues which have a bioethics notion. I'm just putting it up for your information. The tension now of quarantining and civil liberties. We have quarantined many times in different contexts. The smallpox epidemic in Boston really at the end of the 19th century, beginning of the 20th century, is a process that we're going to look at because it actually reached at one point the Supreme Court when a patient, a pastor in Boston, refused smallpox vaccination and was subsequently found to be in contradistinction to the current law at that time, which forced citizens to do certain things. What is the public health response to an infectious event, any infectious event? The stated goal is always the safety of the non-infected American population. The strategy and the methodology has several steps. Increased surveillance or testing. And we've certainly heard a lot about adequate numbers of tests and testing. Mandated reporting of PUI, meaning persons under investigations, to LHD, the local health department. We love acronyms in this world, but the tests have to be reported to the local health department, the results of the tests. Epidemiologic methods, tracking contacts and exposures, which also get reported. So the physician's role now for the use of testing is to track patients and to locate them. Isolation and containment, that's quarantining. Once a patient has been identified, either by test criteria or by serology or by symptom complex, they are to be reported. It is an activity the physician is expected to engage in. Isolation and containment, and then activities to promote public awareness. Please note, there's no element in the public health response that would treat the individual patient. We now come into the notion of the epidemiologic transition, and this is perhaps why COVID is so frightening. The CDC, the NIH, and the World Health Organization at the mid part of 2011 defined the epidemiologic transition, which is a statistical switch from the infectious events of our ancestors, such as smallpox, bubonic plague, typhoid, typhus, and so on, to the modern problems of deterioration and aging, namely heart disease, cancer, senility, and so forth. The American public presumes that infectious diseases are treatable or soluble, sort of a thing of the past. And that's what COVID-19 has changed. COVID-19 is frightening. It's a brand new infection, highly contagious. It has no treatment and no preventative. But if we look at quarantining from the 20th century, and this is mid 20th century, actually this is 1930, when pneumonia was a disease that was quarantined. And what we now do is this notion that we can do telemedicine, and this is 20th century telemedicine, was called a house call. The physician actually saw the patient, obtained a history, examined the patient, looked at the mucosal membranes, listened to the breath sounds, listened to bowel sounds, examined for organomegaly or adenopathy, but actually did hands-on. I don't think that any of the 21st century improvement to telemedicine actually can lay claim to a more ethical way of examining and treating a patient. Certainly you cannot do an examination even of nasal mucosa through a cell phone. Where did our current public health law originate? Where did it come into existence? And this harkens back to what autonomy, informed consent, and the other elements that the bioethics enterprise has asserted as important. First, what are police powers of the state? Well, when the colonies originally endorsed the Constitution, they reserved for themselves certain powers to protect the public health and safety. And clearly, that still exists today. It's a primary duty of the states ever since the founding of the Republic. Frankly, if somebody broke into your house, you're not calling the feds, you're calling upon your local police. And if you're sick, you're not going to a public health facility. You'll find a physician or you'll go to a freestanding clinic, but the care comes through the licensing that's offered by the state, the police powers of the state. The legacy of 9/11 and the anthrax attacks at 9/11 revealed our vulnerability as a society to both nuclear, biological, and chemical weapons. It was the anthrax attacks that changed the way public health regulations would be promulgated. Plans were made following the events of 9/11 for potential infectious agents by both federal and state agencies, in part because the federal guidelines suggested that if a weaponized biological like smallpox were released, that would be an attack on the nation and not just a localized disease event. The CDC became the agency that was empowered to supplement the police powers of the states, in this case because of bioterrorism. The COVID-19 response and the regulations that were written is based on law developed to address bioterrorism. And the picture here of the CDC's interim smallpox response plan acted as a template. The template was developed from D.A. Henderson's successful smallpox eradication campaign in the 1960s to the 1970s. D.A. Henderson should have received, and I hope one day will, the Nobel Prize in Medicine, because recognizing that smallpox only existed as in a reservoir of humankind and living in basically a fully vaccinated world, he was able, using identification, meaning epidemiologic techniques, to isolate and contain an outbreak wherever it occurred, then monitor all the contacts as a so-called ring, revaccinating all cases and all contacts, and thus preventing the spread of disease. Well, that's the model that's used to address any infectious event in 2020. As always, the CDC's bioterrorism plan was tended to by numerous memos that were constantly being promulgated. The CDC goals haven't changed. It's prevent, detect and report, investigate, control, and recover. Again, no real recommendations for the treatment of the individual patient. So the COVID-19 response becomes a derivative of the CDC plan. Post-exposure vaccination, monitor and isolate a ring of people around each identified case to prevent the spread of disease. However, there are no specific approved treatments or vaccinations for COVID-19 as of this date. The plan for SARS-CoV-2, which is COVID-19 variant, is thus a statistical approach that preserves the general healthy population rather than addresses the need of the individual patient. It's a canary in the mine approach. What do I mean by a canary in the mine? If an outbreak occurs, that requires the physicians to report that to the public health department. It is similar to what happened in the Tuskegee study, where the patient was captive. In this case, the study subject was captive to the requirements of the study rather than the treatment of the patient. So again, I would ask, where are the bioethicists in an infectious disease outbreak like this? Is the primary concern only about scarcity and only about rationing and marshaling our resources around that scarcity to protect the remaining healthy? Or is it about also the treatment of the patient? How does it comport with a best practices paradigm and the use of informed consent with either patient or physician autonomy? Can a physician make the determination at the bedside? Not really. We have to adhere to the rules and regulations. And does the patient understand what's going on? It's difficult to say, but without a medical background, much of the information that is being promulgated is really just scary rather than enlightening. So we now have a society, a plan that will require ever greater amounts of statistics to show and justify that what is happening is in the best interests of society. But again, the use of a statistical assessment to show that the right thing is being done will frequently and often leave care of the patient aside. We now look at public health law and individual liberty. These are existing criteria. Public health law isolates the sick, shelters in place. It suspends and/or controls all public and private behavior. It defines physician roles as though we were police, the reporting of PUI, persons under investigation, offering supportive care while limiting autonomous choice for either patient or physician, such as off-label prescribing. It enables arbitrary and non-medical bureaucratic intervention, such as prescription restrictions or essential versus non-essential jobs. And there is no consent process. What are the ethics of quarantining for an unprotected, poorly informed public that is thus twice victimized, once by the disease, then by its public health officials? Where are the ethicists? I put this as a recent, May 6th, from JAMA, bioethics assertion by Ezekiel Emanuel and Govind Prasad, in which again, it's listed as an ethics argument, but community immunity-based licenses or so-called immunity passports. If a person has had a positive serology, in other words, the test is now used to identify the patient, and if the patient comes back positively, then the assumption is that they are somehow immune after their contact, after this antibody quantification. The point here is that issuing a passport will be the same as identifying one population that can go back to work versus another population that is not able to be exposed in the general public ebb and flow of events. There's several problems with this. First, it does segregate the population into two separate categories, one good to go and one not so good to go. It also makes an assumption, a hypothesis, that the presence of an antibody renders one immune. That has not yet been proven and not yet been shown. It's not yet part of the actual science of COVID-19. And probably more importantly, it keeps the ethics industry, as well as the public health industry, involved in making the decisions on what would otherwise be the autonomous judgment of people. Do we feel that we need to stay sheltered, or can we go back to work? The issue of going back to work, or if you will, breaking quarantine, can be achieved safely. We now know that, we know what to do and how to do it. The American public has not fought the regulations that we now are using to keep them, to keep the public in shelter. The fact that they are cooperating, that there is this feeling of we don't need to be coerced into a decision, is not being addressed by the bioethics industry, which seems to have a greater interest in the problem rather than in solving the problem. To look at national health emergencies, especially infectious diseases like this pandemic, we have to take a broader view. The precedent of rules needing to serve the majority interest is a real one. Lincoln did it at the onset of the Civil War when he suspended habeas corpus, so the state of Maryland would not segregate Washington from the rest of the North. Roosevelt did it at the beginning of World War II with the Japanese internment. Public health statutes following any declaration of emergency allow, by statute, the public health authority to control treatment decisions, enforce travel restrictions, commandeer, ration, or control water, food, or medication supplies, and use medical facilities as deemed necessary. The state of emergency is declared via a series of steps that come from the CDC as the coordinating agency. But once the go-ahead and the governor of any state declares a state of public health emergency, it enables public health authorities to control facilities, to order physicians to act in certain ways, and to order citizens to submit to examinations or treatments. The refusal to agree is prosecutable. Quarantine is enforceable. Public health officials and their workforce are immune from prosecution. They are immune from liability for their actions, even if that leads to disability or death. And the definition of a public health emergency is an occurrence or immediate threat of an illness or health condition caused by bioterrorism, by epidemic or pandemic disease, and that poses a substantial risk of a significant number of human fatalities or incidences of permanent or long-term disability. This is not a great definition because it's much too broad. Theoretically, every flu season, HIV, syphilis, any disease that's contagious can be included in this definition, and a state of emergency can be declared. We came close to it with Ebola, and SARS, but the issue of that actually turning out to be as disabling or untreatable was put to rest, and a declaration didn't occur. That's not the case with COVID. Let me just move this out of the way. The governor under the state of emergency is permitted to suspend state regulations, to change the functions of state agencies, to mobilize the militia, more or less to enforce the quarantine or sheltering in place or other activities such as doing your hair in Texas. Anyway, it does exercise control over our civil liberties. The failure of physicians and citizens to follow the orders of public health authority is a crime. In my state of New Jersey, if a physician is accused of and convicted of a crime, your license to practice medicine is forfeit. And that especially comes up when you need to declare at renewal of license your record, if you will. Given though that there was and is a high level of cooperation on the part of professionals and the public, one has to question, is such coercion necessary? Again, I would ask, where are the ethicists? Public health must be in charge of let me get this out of the way, it's not going. Okay. Public health officials must be in charge of a pandemic response. It's too big to handle when it's so global at the local level. But there have to be local regulations that would allow us to be autonomous in making our medical decisions. There has to be an informed consent and treatment option. And we are just not able, under these circumstances, to see this action when it's arbitrary, as being anything other than unethical or lacking constitutional background or being justified. The primary role of public health is to provide guidance to both the public and to the government, to any officials in identifying and dealing with COVID-19, provide lab facilities to evaluate and definitively diagnose, and try to limit exposure and spread of disease. But the role of sheltering in place and social distancing, which is considered useful and important, especially at the onset of an infectious event, if it alters all of our civil liberties, it has to be exercised with not just constraint, but with responsibility, trust, oversight, as well as accountability, as well as liability. And since our current situation, in the absence of any treatment recommendations, offers no treatment to the patient, we have to be that much more clear and safe. The medical care of patients remains the responsibility of the medical profession. The public health community is not going to be at the bedside. I want to know again, where are the ethicists? And a point that really is necessary to emphasize is that historically, large-scale quarantines have little positive effect on epidemics. Apparently, microbes do not read guidelines and they don't choose sides. And that's not news. It really comes down to the fact that while contact with an infectious agent, especially where you have different populations with different susceptibilities being defined, we can expose to what coronavirus is and are. They are the cause of a common cold. And common colds have always been regarded as benign or self-limiting, which is why most of the attempts to create a viral vaccine for the common cold have not really been pursued. But the point here is that we are limiting, because of quarantining, the ability of the population, of all of us, to develop herd immunity. And it will be herd immunity that ultimately limits the impact of the infection going forward. Civil liberties, autonomy, and the public health emergencies in the 19th to 20th century had a persona. The trade-off was between civil liberties and effective public health interventions. And in this case, 19th to 20th century was because it was assumed the public would not cooperate or didn't grasp the key issues. The precedent was the Jacobson versus Massachusetts lawsuit that I referenced earlier in the last smallpox epidemic in the United States in 1902. But 1905, the case that was brought by Jacobson against Massachusetts was heard by the Supreme Court. The Supreme Court said effectively that the good of the many trumps the requests or the concerns of the individual. But this is the 21st century. And in the 21st century, autonomy in medical decision-making has become a central aspect of the bioethics enterprise. We have the right to refuse treatment. We have the right to choose methods and means, even if the choice leads to death, such as stopping hydration or ventilation in a patient that is considered ill and with a futile prognosis. Centrally planned and controlled healthcare does not provide individual patient care. Autonomy as a concept has been erased by the intervention of the public health community in the COVID-19 events. So what are the conclusions? The CDC has detailed its response to infectious events like COVID-19 based on a plan that was used, that was crafted around the deployment of bioterrorism around weaponized microbes. Public health's role is to recognize, report, contain, and advise. Public health law currently dominates clinical decisions, modifies professional conduct, controls the public's comportment, dominates commerce and business, rations or controls medication, food, water, and facilities. In sum, limiting clinical choices and denying all autonomy as well as civil liberties As such, public health law is ethically challengeable and probably legally challengeable as well. Public health law and regulations that are advanced to achieve the goal of protecting the health, safety, and welfare of Americans can and should abide by the same ethical standards to which all the healing arts are held, and there should be liability and accountability attached to these actions. And with that, I wish you well. Stay healthy, stay well. Thank you for listening. Jeremy, are you there?
Yes, yes. Thank you very, very much, Dr. Dobken, for that enlightening presentation. Very important information. And so we have about a half an hour now for Q&A and discussion, and there's already a good deal of a good number of questions coming into the Q&A box.
I'll stay with you as long as I can, okay?
All right, thank you. Thank you.
I ran over, I apologize.
No. So we'll plan to stop at 10.
Okay.
So we have a little bit of time here. And so, if you'd like to ask a question verbally, please click the raise hand button and we'll come to you.
There's one more slide, Jeremy. It's not really part of the talk, but
okay.
It's just recommended reading. It'll be included with the PowerPoint when we distribute that. But the book Thieves of Virtue by Tom Koch is absolutely one of the most excellent sources on the bioethics enterprise. And Seamus O'Monaghy's book on Can Medicine Be Cured is more than a curiosity. He's in the national health system in England, in Great Britain, and I think we will all profit from it. It's a funny book too, so good toilet reading.
Okay, excellent. Thank you. So what, let me, I'm going to go back to our normal video here. Okay,
good.
So we have a number of Q&A questions in the typed in here, and I'll start with one of them. A physician wants to hear your feedback as a pediatrician on on the new findings of Kawasaki-like syndrome in children who have tested positive for COVID. And the doctor is asking that question because they're wondering about how that might be used to further limit civil liberties, i.e., harm to children is often used as an excuse for taking away rights or passing laws. Any thoughts on that? Good, interesting.
It's a good question. Yeah, there is every reason to trust that there is a Kawasaki-like presentation, especially when the virus itself has so many potential risks. Coagulopathy has also been seen as a problem, and neurologic presentations. I would like to see more data to give a better answer than that. I do know that there is still a sense that the very young, the children, tend to weather the storm, the COVID storm, better than others. So whether this is going to become a greater or lesser problem remains to be seen. Again, we're back to how many more statistics do we want to have thrown at us? I would proceed with caution to blanket every child as having the potential of going into a Kawasaki-like syndrome.
Thank you for that. Okay, we're going to go to a verbal question here.
So the question I have, in the event that we really develop strong evidence that this resulted from an escape from the Wuhan viral lab, does that change the ethics of the federal government taking control as an assault on the country? Obviously, if it was weaponized and released on purpose, that would be bioterrorism. But how about your thoughts on an accidental escape from a bioterrorism laboratory?
Yeah, if I get your question correctly, is would the release of a weaponized microbe constitute an assault, a bioterrorist assault? And would that change the way that we approached this international pandemic? Is that about right? Is that what you're asking? I'm having trouble hearing.
Oh, sorry. Let me bring him back here. I muted him again. Sorry about that. Just to here, Dr. Title, I'm going to bring you back here. All right. Sorry. You should be able to talk again.
Did I get your question correctly?
You there, Doctor? Are you there?
All right. I'll give my
sorry.
answer.
Yeah.
Look, the Wuhan lab is supposedly a level 4 lab. So the possibility that the virus was being manipulated and got out of control or left the laboratory in an unexpected manner or an intentional manner is yet to be established. I think we have to be fairly careful. Germs tend not to have return addresses on them. The point of what I think we need to be concerned about with this is get enough data to understand whether or not it was manipulated and then act accordingly. It should, if that's the case, comply with what they were doing with reporting the smallpox case as being an assault on the nation rather than just a coincidental infection. That's why all of the provisions about physician reporting to public health reporting back to state reporting to feds, it leads a whole trail of processes in place. Do I think it came from a laboratory? Like I said, germs don't have return addresses, and I think it would be a disservice to try and label it without that evidence. If we have the evidence, then we should act.
Okay, so we have another raised hand here, and we'll go to Dr. Lewis. Dr. Lewis, please go ahead.
Hi, good evening. Yes, I've been very concerned about a lot of what has gone on in terms of just a lack of basic science and understanding of virology, and looking at previous pandemics and what has happened with those, and in terms of herd immunity. And it just seems concerning to me that they're throwing all of that science and understanding of virology out of the window. So my question for the panelists is, what is the accountability of physicians like Dr. Fauci and Dr. Burke, who are really driving the conversation, but they are non-clinical people? And someone like him, and especially his trial recently of remdesivir done at his own NIH, in National Institute of Allergy and Infectious Disease, actually has some serious scientific flaws. They keep changing the placebo group and the amounts of people and all sorts of things, and then him tossing out hydroxychloroquine, despite the fact there's actually some very good studies in France and some other places, and it's a drug that's been around for many years. At least it should be allowed into trials. And for him to say, well, it's being used off label when we use antidepressants and drugs like that in children all the time. And yet he's touting a more expensive drug. And I do feel, the thing that probably upset me the most and made me the most concerned is when those two doctors in Bakerfield were presenting their own data, not telling everybody to rush out, but just presenting their data and giving their experience, which correlates actually with lots of other pandemics. Typically, these pandemics burn out after 2 years, and it often is because of herd immunity. Though they were actually banned. And then Fauci also, I think my final point is that concerns me is there's more and more data. National Institutes of Health have even come out and said ventilators should be a last resort, that there are other better methods. And we've seen almost 100% mortality rate on ventilators. And yet there's no public health commentary on that from the CDC or from Fauci and Burke. And really, good advice to hospitals and clinical physicians and things like that. All of those questions, and they're just one of few, really concern me, because I think we have seen viral mutations and pandemics for centuries. And, the Hong Kong flu in 1968 was a classic example. If we extrapolate those numbers to the current US population and world population, This pandemic may not even be as bad as that, and yet nothing was done. And you know, viruses, it's normal that we do develop herd immunity, and the data keeps showing. So my concern is that Fauci and Burke are being allowed to override almost all scientific discourse and actual clinical physician experience in this virus. And I would like to know what the panelists think about that.
That's actually an excellent question, and you've made some very good points. Those, in point of fact, the lack of the intervention, let me put it that way, that the public health community, Dr. Fauci and colleagues, have placed this restraint against interaction people to people, and the need for herd immunity to actually emerge from that is a core point. Why why the public health community should not be held accountable is one of the points I was trying to make in the discussion, because they are making decisions which reach down into the bedside treatment of the patient who is ill. The issue of what to do and how to do it, however, for Fauci and colleagues is based on the goal that they have, and that's to preserve the health of the remaining healthy population. They keep the herd well, but the cow that's sick is too bad. And we, the physicians, are at the bedside and making the decisions, and to have that complicated by the fact that we're not allowed to make the decisions that may be useful, such as the use of hydroxychloroquine, that is no longer left in the hands of the physician. That's been handed to the bureaucrats and to the public health officials. It's wrong that they should not have liability in that, but again, for their mission, for their goal, it's to limit spread and to keep the remainder of the population healthy. I don't think they're achieving their goals, but that's just my personal opinion. We'll know better in a year when we can look back at this epidemic and see what the statistics actually read. And I guess the other part about this is the definitions of who has the disease and who has died of the disease, and the rest of the so-called solid data that's being distributed is difficult to interpret, because even from state to state, a COVID-related death is not well defined. And that puts a real hiccup in this interpretation profile. I don't think that the public health community should act as if we, the medical profession, are their enemy. We're willing to cooperate, but we can all work together. We have our job, they have theirs. Let us do ours, you do yours.
Thank you, Dr. Dobken. So yeah, you touched on in your answer there, you touched on another question that we have, that was wondering what you thought about Dr. Zelenko's work in treating COVID-19 patients with hydroxychloroquine, zinc, and azithromycin. And so you did touch on that. Any other thoughts on that? Are you about Dr. Zelenko's protocol, if you're familiar with it?
I'm not familiar with his protocol per se, or her protocol, right?
Yeah, thank you.
But I do have, I don't see a reason why hydroxychloroquine and the azithromycin and zinc should be banned as a prescriptive.
So just sort of coincidentally, the New York University Grossman School of Medicine put out a paper on May 8th, just a few days ago, about the combination of those three drugs, and with their data shows that that it's promising that those drugs might be helping some patients. So if those of you who are interested in that, go look for that New York University paper, and I can email that to I'll put that in a link to that in the chat room here.
Okay.
Okay, so here we'll take another question here from our Q&A typed questions, and this is a little bit, might be a little controversial here. He's asking, Are you suggesting that individual civil liberties should prevail over bioethical population concerns, specifically if there were a highly lethal, highly transmissible viral entity that was impacting our nation?
I don't think I quite understand what was being asked. Do I think it more important that we preserve the health or well-being of the population versus the individual if it's very, very contagious?
Right. How does that change the calculation, the balance between civil liberties and what public health authorities can do or should do? That's how I'm interpreting this question.
Okay. I understand the question, and I would state that that's really there. You've embedded two different issues. Ethics are not controlled so externally. If a catastrophe happens, and they do, at the beginning of any event that threatens the health and well-being of large populations, one has to take whatever measures necessary. But there comes a point when the one-on-one, what do we do for this sick patient in front of me, doesn't have to be embellished by external events, other than to note what our obligations are for that patient. So ethics, I don't want to mix ethics with treatment. Though they overlap, they're not one and the same. And it's still the role of the physician to do no harm, to enter into the treatment scenario with the best interest of that individual patient in mind. So that would be my view. I don't think that ethics per se and the public health authority and how they behave mix and match very well right now. Does that help?
Yes, thank you. Thank you. So we'll go to another verbal question here from Dr. Fleck. Dr. Fleck, please go ahead. Are you there, Dr. Fleck?
Yes.
Okay.
Can you hear me?
You're a little soft there, so if you could speak up a little bit, please. Thank you.
Okay. I just wondered if Dr. Dobken was aware of any lawsuits or even congressional action like bills trying to be developed to provide for medical malpractice and liability for these public health officials in cases of government overreach like we've just seen.
That's an excellent question. And my response to that is that the current law as written gives immunity to public health officials and to bureaucrats that are involved in enforcing a shelter-in-place order, for example, or restrictions on prescribing and so on. That is inherently wrong in my view, and it should be corrected. I don't know of any lawsuits that are being brought or that are anything other than likely to be dismissed. But again, I'm not a lawyer, as I said at the beginning. Just another handle.
Yeah, thank you. Thank you. So this is an interesting question. This doctor wants to know if you'll take a stab at this. Where are the ethicists? You asked that, but what do you think the answer is? And he goes on to say, are the voices indeed being actively silenced by the likes of political leanings of JAMA and the so-called experts like Ezekiel Emanuel?
Great question. Ezekiel Emanuel, by the way, is one of the leading voices from the AMA. He is and has been in charge of CJA, which is the Council on Ethical and Judicial Affairs of the AMA, and he has control over many of the publications and has been quoted in the New York Times. He's an expert in the media, as are many of the bioethicists. My view of how they behave and what's going on is that And I don't want to get too far afield as far as conspiracies are concerned. But frankly, the ethicists have a greater stake in the problem rather than in its resolution, which is highly unethical. They're called upon, they make money, they're called upon to have an opinion, speak in the media, develop a perspective for a political party or for a for the public health authority. That compromises them in my mind in terms of their objectivity. But like I said, they don't want to solve this problem. If they did, if the bioethics community really wanted to address the ethical issues, it would be about what to do to solve it, not what to do to sustain it. And that's part of our problem.
Okay, no, thank you. Thank you for taking a stab at that there and for that information. So we have just a few minutes left and we got a few more questions. Let's see if we can tick through these. So this physician's bringing up the issue of cell phone data and says it's been proposed to use cell phone data to track everybody's whereabouts in order to trace contacts. A less restrictive methodology would be to determine membership in mixing groups and determine the amount of disease transmission due to the particular mixing group without being intrusive into people's privacy. I don't think I saw privacy as an essential medical ethic. And he's wondering if that is part of autonomy. Is privacy part of the concept of autonomy? And does the government have the obligation to use the least restrictive means to accomplish their policy objectives? I guess in regards to patient privacy or citizen privacy.
The law actually is written in a way where, and it includes that language, the least restrictive measures that do not supposedly compromise our freedom or civil liberties. But it's difficult to see how that works when you're told you have to stay at home, and if you're not at home, you better wear a mask, and if you don't wear a mask, well, you're going to get arrested or you're going to get fined. We're kind of looking at this conundrum of how to both cooperate with the arbitrary and coercive nature of the regulations that are coming out as if there was still the 19th century, rather than looking at the 21st century when we can make decisions for ourselves, even if the withdrawal or withholding of a treatment leads to death. The point that I think needs to be emphasized in general for what would be the right thing to do and how to do it would have to include a way to assure that our civil liberties can be, if not at least assured, that we can at least defend them and have a proper hearing if though God knows that's going to only cost a lot of money, but ways that we can assure that our civil liberties are not taken away in this rush to flatten the curve, I guess is the current perspective. So difficult problem. I don't know that it'll be solved in this crisis, but that would also, in my mind, be a topic for ethicists to address going forward. I don't think it'll happen.
Okay, thank you.
Don't even need to be negative, but
Okay.
the track record looking pretty bad.
We're going to go to one of our past presidents here, Dr. Al Fisher. Dr. Fisher, are you here with us?
Can you hear me now?
We can. Yes, please go ahead.
We understand quarantining the sick, but now we have what amounts to quarantining of the healthy. And isn't this something new that we've never had before? Is that in the laws? Isn't that a violation of our freedom?
It indeed is, but the precedent has been set before. If a family, for example, has a member with smallpox, even going back to the beginning of the 20th century, the whole family would be locked in to the quarantine just to prevent the spread of the disease, the disorder. That now happens as well in some of the settings for multiple drug-resistant tuberculosis and several of the other infectious diseases that don't seem to have very good answers. But whether or not it's new or unprecedented remains to be seen. But the healthy and well are in the lockdown mode as well, and that applies to so-called serology positive patients who are asymptomatic and in the same setting as a family member who is sick. So it's a good question, and I don't think it'll really at this point be resolved. The bureaucracy and the political climate are acting against good resolution. The shame is what Mr. Schlafly said in his first webinar, and that was that it's too bad that COVID-19 is happening in a political year. And it is. It really is a shame, because it's politicized a medical issue rather than allow it to be addressed by medical experts. Okay.
Yeah. Okay. Thank you. Thank you. So we're very close to needing to end right now. There's just a couple quick questions, and I think I can tick through these very quickly. Someone's asking about FDA off-label use. You know, off-label use only requires safety, not efficacy, to be shown, and we use off-label meds all the time. Why is that trying to be curtailed now? Any thoughts on why that's happening? Why are entities putting their thumb down on off-label use at the moment?
Frankly, I'm puzzled by that too. We certainly have seen enough data that came out. Let's face it, the country of India and their statistics, South Korea and Japan, and several of the other nationally used, France, I believe also. There's no reason that we should not be allowed to make that decision on behalf of our patients with informed consent. But apparently that for whatever reason, it is not being allowed. And I don't have an explanation for that.
Thank you. Thank you. One of the commenters was mentioning that problem in the related to antibiotics, how now doctors' prescriptions for antibiotics are being second guessed, and he's raising that concern. And so thank you for raising that. Also, someone's asking what AAPS can do to assist physicians in restraining out of control government regulations or orders on citizens at this time. And they mentioned Washington State. You know, if you would maybe email us some of the specifics of what's going on in Washington State afterwards, I'll be happy to discuss that with you. And so with that, I think we need to wrap up. Dr. Emmons, I'll kick it over to you here. And I just wanted to thank our speaker, Dr. Dobken. Thank you so much for the enlightening talk and answering so many questions tonight.
Yes, thank you again, Dr. Dobken. Your presentation was just as compelling and informative as we expected it to be. And as you said, you wanted us to go away with lots of questions and not necessarily definitive answers, and you've certainly succeeded at that. Jeremy, thanks as always for your help with organizing, and thank you to all the participants. Lots of you are coming on a regular basis, and that's really what we want to promote. We're going to be doing this every other week on into the future, and we want to build our own collegial community here and keep meeting on a regular basis. So we'll look forward to the next time.
Yes. Yeah, thank you, everybody. And just a quick reminder, you know, there are still a few more questions. I see a couple more raised hands. If we didn't get to your question, please respond to the post-event email, and we will work on getting your question answered. I apologize we can't get to all of them in person right now. And as I mentioned you will be getting a post-event email. The important thing about that is you need to fill out the evaluation. You need to click on the link to fill out the evaluation in order to get your CME certificate. That's very important. And with that, I'm going to say thank you once again to Dr. Emmons for helping us lead tonight's presentation, and especially to Dr. Dobken for all the work that went into putting this together. And from all of us at AAPS, have a good evening.